Thanks for joining us on our STT webinars. We are starting, so this is our first one on this new era of webinars where people are not used to webinars anymore, because now COVID has been gone and people have gone back to face-to-face meetings. When, of course, for a telehealth society, distance and technology at a distance continues to be quite relevant. One of the reasons why we've decided to do this series always on the first Tuesday of the month, which of course in this case is too close to Easter, but I hope that many people will then use the recording of this session to their benefit and to learn about this project that has been chosen to be the focus of today's presentation. We also would like to extend the interest to all participants from the SIT and anyone else to suggest to us through our email any topic for discussion. Feel free to suggest. And now I would like to not take longer and give the word and the stage. I presume Alba and Alberto, you'd be sharing the slides from your side. Is that okay? Yeah. Do you have the sharing function on Zoom, or do you need me to give it to you?
No, we have it. I think
you have. Okay.
Yeah.
Basically, the Rosia Rosia stands for Remote Rehabilitation Service for Isolated Areas. Is a project that will deliver comprehensive service to patients in need of rehabilitation, enabled by cutting-edge technology, new care pathways, and community support. The project is led by the Instituto Aragonés de Ciencias y la Salud, and it's going to be presented to us by our esteemed colleagues. We have just invited them to join our society as members. Let's see if we can convince them. Over to you. The floor is yours. I would suggest maybe we can have a 25-minute presentation, and then we have time for the colleagues from the society to ask questions, to further discuss how we can do more on tele-rehabilitation. Over to you.
Thank you, Enrique, and thank you for inviting us for this session. To this session. I'm Alba de Martino, as you said. I work in the Instituto Aragonés de Ciencias de la Salud in Zaragoza, and together with Ms. Alberto Vallejo, he works in IPN, Instituto Pedro Nunes in Portugal, and we are here representing the whole consortium for the project, and we divided the presentation into parts. So I will share let me see, where is my, so I have so many things open.
No worries, we have time.
Oh, sorry, let me check. I don't know why I can't find this now.
Do you want me to share the presentation?
Give me 1 second. Here.
Okay.
Yeah, I think it's this one. Yeah. Do you see it in presentation mode?
Yes, but not
yet
for now. Yeah, okay. Now it's okay. Now it's good.
Okay. So yes, as you said, let me move here everything. As you said, Rosia is a project that is for remote rehabilitation service for isolated areas, and it's not a project that we are used to in research, at least, because although it's funded to the Horizon 2020 program, it's a pre-commercial procurement project, and it's pre-commercial procurement of innovation, or in this case, pre-commercial procurement. It's a tool that the European Commission has to develop and provide different solutions. And in general, it's co-created. The solutions are co-created by the companies, and also in this case, the providers of care. So it's a tool that is very useful, in my opinion, is very useful for the healthcare system. And we started in January 2021, and we will luckily end and successfully end by June 2025. And we are 12 partners, so 5 countries. IACS coordinates the whole project, and we have 3 public procurers that are Servicio Aragonés de Salud, so it's a regional healthcare system in Spain. El Centro Hospitalar Universitário de Coimbra in Portugal, and the National Rehabilitation Hospital in Ireland. And here, when we were designing the project and to apply for this topic, we were discussing a lot about the rehabilitation as it is now in different countries, in the 3 different countries. And we wanted to design or co-design the future of rehabilitation services especially for remote rural areas, because Portugal, also Ireland, and Aragon in this case, but all other parts in Spain, we have a lot of population that is getting old, and vast territories that are low density regions. They are far from cities where the main hospitals are, or the rehabilitation is provided. And with this in mind, we wanted to design or help design a service to have so that people can have equal access to intelligent tele-rehabilitation services, including obviously rehabilitation specialists, new technologies, the social and health services around the areas where people live in, and the community resources. So, well, as I said, we were thinking in low demographic density areas, and also the aging population. We will all be aging at some point, and what we see is that there are solutions supported by new technologies that can match the needs of the patients and the healthcare systems. But these solutions are usually dispersed, meaning that there are apps in general, but they cannot be prescribed or not as a service. We also found that there is no, and it is not integrating. There's not a service as a whole integrating different things that were needed. And what we wanted to do is, okay, let's try to unlock the market and develop an ecosystem that I will explain later, the ecosystem parts, but it has an open platform that integrates the services based on integrated care model, and ensuring that it's sharing. I mean, the care plan is included in these services, and also it has a catalog of applications that can be prescribed by the healthcare professionals, and this accompanied by the whole community services. So we had, like, I would say, 5 cornerstones here. That is tele-rehabilitation, integrated care, patient empowerment, and value-based healthcare. So it was very ambitious when we were writing it. I still think that is very ambitious. So it's being quite difficult, but we are still there, and I think it can be a good solution. So let's see. As I said, we are 12 partners. So we have a buyers group represented by 3 different European healthcare systems: Salud, Coimbra in Portugal, and Ireland. And this is like a picture of the procurers, as I said, coordinators, and also we have the procurer coordinator. We have knowledge partners in different areas, like the decision group, for example, that is a specialist in value-based, or Instituto Experiencia del Paciente, to see the patient's need. Also, all the technology area covered by Instituto Pedro Nunes. And for the integrated care, we have a foundation, and also PPC, and that is a specialist in technology too. And here we have what we, afterwards Alberto will explain, but here we have also areas where we are going to pilot the solution that we now have on paper. And this is in Aragon, we will be Barbastro healthcare sector and Teruel healthcare sector, Municipio de Penela and Municipio de Soure in Portugal, and the hospital in Ireland, the Rehabilitation Hospital in Ireland. We selected these areas because they are the population is dispersed or has the rehabilitation needs of the patients, and covers all the challenges that we are facing. As I said, why we thought of this project for this tool that is a PCP. We know that the patients that need rehabilitation usually need to travel a lot, at least from regions that are dispersed, like in Aragon, for example, and also these municipalities in Portugal. So to have the services, tele-rehabilitation services, and the clinician supervision. So this is something that is preventing sometimes that all the services and all the process is finalized or ends. And also something that it was found by the clinicians is that some patients would need an extended period of rehabilitation, and they don't have it because they can't travel, or they live in areas where they cannot have this support for self-management and self-care. So we thought that this was something that we could address with this project. And also, in general, the healthcare systems, as we know, and we'll see the pandemics, we have limited resources. We have an increase in demand, and we have aging and rising cases of chronic conditions. This from, in general, for the healthcare systems in Europe. And this is intensified in low densely populated areas, because we also have higher proportion of elderly people and longer travel distances to access services equally. So with this in mind, we thought, okay, how do we design this self-care model for chronic conditions? And we started with rehabilitation. But it's not for, I mean, this could be applied to other diseases and other needs for telemedicine. But we started with rehabilitation because we thought that it was a good case. So, and thinking of the solution when we wrote the project, we thought we needed a community, so supervised community, and self-care rehabilitation at the patient environment. This is very important. So when we chose the different sites, we know that we are facing a challenge that is the environment, so local differences, and we are seeing this. Also, we need a flexible and scalable value-based model of care. So we are also defining what is value in this case, and this is also a topic of discussion. Also, how we are doing the integrated care, so how all the pathway is integrated, everything is integrated in the patient's pathway. How we face the lack of motivation when people is isolated and need to do exercises or need to do the rehabilitation plan. So how we address the community and how we design virtual coaches or other tools for this motivation. And some of them can be disruptive solutions that we were looking for, and also with all health-related data issues and regulations, we need to address these too, especially in the healthcare. And we wanted to be an open platform, so that is, it was not commercial, and that it can change. The applications, for example, and the solution can change with the time, and that some applications and some solutions that are not now in the pre-commercial solution or the first prototype can be implemented afterwards. And obviously these apps and different devices need to be certified, so they can be prescribed by the different and validated, so they can be prescribed by the healthcare professionals. And I will go a little bit into the challenges and how we are thinking in the project, how we are thinking of these challenges. As for the integrated care, we are thinking in a plan that is joining an interdisciplinary team, and that it has one part for digital and health literacy. We know that in remote areas and rural areas, it can be that there's no internet connection, for example, and there's no, or maybe there's less knowledge on different digital tools. So we need to address this. We also need to be very careful with the care team. So the collaboration and coordination is quite close. We need to involve patients and families around the patient for a shared and personalized decision support. So design this support. And we also need this to be reviewed and monitored along the whole process by the healthcare system, from the hospital where the rehabilitation services are to the patient's home. For this motivation and active patients supported by the community, we are thinking in how to empower patients and the community so we can providers' personal services, also virtual coaching, and use personal data with with all security and safety, but to give advice to the patients, and how to involve the whole community around it. And for this motivation and active patients, thinking of rural areas, we were thinking of enhancing and developing social networks. So the physical, both in the physical, but also in the digital world, have peers for patients and carers, and promote different health, also in the rehabilitation practice, but also promote healthy lifestyle, well-being, mental health. So include all the areas that goes along with the rehabilitation, and from the community go to a reduction of isolations, and how to involve the community for better informed patients, and how to reduce this isolation. So this is also a huge challenge here in the project. And this is all based in the Rosia ecosystem that is technology-based. And we were thinking, okay, how we create a safe, innovative tele-rehabilitation ecosystem plus an open marketplace that empowers patients and healthcare professionals for rehabilitation. That was the question floating around all the project. And okay, what was designed is like a 3-layer ecosystem. We have here at the top of the iceberg what the patients and professionals, healthcare professionals, will see. That is apps that are safe, certified, and all together with devices that can be prescribed. As I said before, it needs to integrate technology for different third parties, and need to address the needs of patients, professionals, and caretakers. And here we have like evaluation, vital signs, and training programs, exercises. So a lot of things and services all together there with the applications and devices. There is a Rosia developer layer that is an architecture to define these different APIs, so they are interoperable with the systems that are already used in different healthcare systems. This is also a huge challenge that is that it builds taking into account what it already exists in different healthcare systems, and that is modular. So it can also connect with other initiatives and other solutions, and it can grow and change with time. More or less, this ecosystem will look like this. So it's based in an open platform that I will show now the wish list for this open platform. But here the healthcare organizations and professionals have a dashboard where they can define and see the care plan, and they can do the follow-up. This is connected with the social community and the patients. We have a data repository with all data, so this nurtures the platform and this dashboard. We have different technological components, and we have a catalog that is open with all the services, apps, and devices for the patients. And as I said, the Rosia platform, when we designed this platform, we thought of this wish list, and we wanted this to be very flexible, that the platform can share data across sectors and facilitate the involvement of patients. That is automatic, obviously, that it can be light in interfaces, but good in infrastructure, that is supporting different medical devices where it's feasible, that is taking into account EU national regional infrastructure components as first choice. Obviously, it's based on standards. We don't want proprietary solutions because this has, as we know, a lot of problems. That is cloud native, the platform, and that lets the citizens to share data and for research as a secondary use, and also that is secure and safe enough not to be identified, and that gives full control to the patients of their own data. And as I said also previously, we were and we are defining what is value in this project and for Rosia. And here for the companies and for the solution that is now being piloting, we want to be sure that we measure the outcomes and not just the volume of services delivered. So this is for the companies to take it into account, but that we are sure that what is value here, that is health, how the health is improved in rehabilitation, but instead of the number of services provided by the companies. And we found barriers, obviously, and some recommendations to implement the Rosia solution, but because our idea after this PCP that will bring, hopefully, a solution that is pre-commercial, but is in the market, the idea will be then scale it up, see if it works, we hope so, and scale it up to the healthcare system. So we have some barriers. Here, in this use case, that is still rehabilitation, that is for the healthcare system, that implies transformation of the healthcare, how it's provided. This is always difficult. We need to design or redesign the care model. So we also need to put a lot of digitalization here, so interventions, and that is personalized. We have, as I said, the data issue and everything that goes along with it. And for the developers that are vendors and innovators designing application, etc., they will find fragmented care models, and this is really, really important here. The diversity of ICT, health systems and programs and different healthcare systems in different countries. So they need to put a lot of effort in integration. And difficulties to scale up due to regulatory things, so regulatory barriers, and lack of interoperability that we know that we have in the healthcare system. And here the recommendations will be, we need to increase connectivity, as I said. Some parts, maybe they don't have even connection, so this is something that is also difficult to address in isolated areas, and also foster digital skills for patients, but also professionals and especially the elderly, and improve healthcare services and empower the healthcare staff in remote areas. That is also a challenge, or at least in our area, in our region, is a challenge. So we are able, maybe with projects and innovations like this one, to attract healthcare professionals to rural communities, maybe inspire and engage students and young clinicians to opt for rural health. So maybe digitalization and telemedicine can be something attractive for these young students and clinicians to opt for a different place to work in, and also improve the health staff working conditions in these areas that we know that is very, very hard. And now I give the floor to Alberto. I don't know if you want to share the presentation, and or if you want me to.
Maybe it's better.
Maybe it's better that you share, or
Yeah,
that...
yeah.
Okay.
Maybe it's better.
Okay.
Are
so
you hearing me well?
Yeah,
Okay. So I will try to be brief. Well, I have the not so interesting part, because now I'm going to explain a little bit about how we monitor this competition between the companies that were awarded here in Rosia for implementing this ecosystem. And in fact, we are using an instrument that, like Alba said before, the pre-commercial procurement, that is a very important instrument that the public entities are empowered to use them for getting tailored solutions according to their needs. So it's a kind of different from the traditional procurement, where they have to buy something on the market that already exists and it hasn't a perfect fit on their organizations. We are talking here in health organizations, but we can talk, this instrument can be used by other kind of sector, not only on health. This pre-commercial procurement is divided in several phases, and for the first phase, for phase 0, we have we consult the market, and that was one of the job here in Rosia. For doing that, we did the state of the art. We model more or less how we going to implement or what we would like to see on the Rosia ecosystem, like Alba already explained, and then we made a call for tender to every companies that were involved in this open market consultation. So the ones that were awarded, they entered in phase 1, and they did the solution design. Then they also have to apply to the second phase, but only restricted to the suppliers that were awarded in phase 1 for the prototype development. And right now, in Rosia, we are waiting for the selection of the suppliers that will do the phase 3. It will be on the field in 3 regions: Ireland, Spain, and Portugal. And finally, after these tests and validation of all ecosystem, of Rosia ecosystem, there is another instrument that we can use, and that is the public procurement of innovative solutions that we can use for deploy commercially these as a product, these prototypes. Basically, these are the building blocks, and as Alva already explained, there are three main blocks that are technological blocks. The open platform, the developer layers that is related with the companies that would like to put their solutions in the catalog, their tele-rehabilitation solutions in the catalog, and the catalog itself that where the clinicians could use for prescribing the solutions, the rehabilitation solutions to the patients. These were done in phase 1 and phase 2 with and now we are waiting for select the best prototypes for phase 3, where we will try to put on the field for see if it works as we expected, as Rosia expected. Well, mainly for controlling. Well, this is a huge project, and this is very important to have like a systematic way for monitoring and control all these things. And we put in place 2 layers, main layers. The monitor layer for the phases for where we execute the implementation or the solution or the prototype, or then phase 3, the test, the validation on the field. And also another layer, the evaluation layer, that is regarding the evaluation of the proposals that the suppliers submit to us. So of course there are we constitute 2 boards for that, a monitor team for monitoring the contracts, and the evaluation committee for the evaluation of the proposals before each phase. And also there is some milestones in each phase. For instance, the last phase, the second phase, it lasts 10 months with 3 suppliers involved. They had to deliver some evidences about their work, and they were evaluated, and in each diamond they correspond to a time where we assess all the work done, and we say, well done, so we are going to pay. So we have that also. This is all more or less defined in these pre-commercial procurement. So we are not inventing nothing. This is what we have for the pre-commercial procurement. Now I will rapidly talk about the layer, about how we evaluate these called the proposals for each phase. So we have an evaluation committee that is composed by 70 members, 4 members from each procurer from different technical background, and also the lead procurer, that is the Instituto Aragonés de Ciencias da Saúde. They have 5 members, 1 member more in this case. So 17 in total, and also we have an advisory board that 2 members here present here in this webinar are also members, and the knowledge partners that already Albert talked about it. That are some partners that have some specific expertise on some areas that help this evaluation committee on deciding on their evaluation. So I'm going to be fast. So these are the steps that were used for evaluating the proposal. So the companies, all the companies that were applying to the call, they need to submit to a platform, a public platform. In this case, Spanish, because the lead procureur is Spanish. 3 envelopes, one administrative, one technical, and another one financial. And these envelopes were opened in parts. This is more, it's similar for the ones that know how the procurement, public procurement works. Is more or less the same. And there are some criteria they need to pass, and if not passed, they are rejected, the proposals. And in this case, for the technical envelope, this is the part that was more hard in terms of work, because they had to individually assess all the proposals, and in the end they made a short list with the score of the proposals. And finally, when we opened the price for each proposal, there is an equation that is used for having the last list of ranking list. So, and the ranking list then is, there is a budget, and when the budget there is no budget, so the final list is selected, and it's how we are doing for each phase. Before each phase, we do this. Well, not all, because there is some steps that we don't need to do for phase 2 and 3. Regarding the monitor of the contract, because they have to, for each phase, if they are awarded, they need to sign a contract where they have to the duty to provide some deliverables as evidences, and also in some the contract also describes how the intellectual property will be used, if the procurers will have access to the licenses to use the software, and so on. So the contract have everything. In fact, these are the list of deliverables for each phase, and right now we are waiting for entering the last phase for doing that. These deliverables that will be provided by the contractors, and the team that was along with the evaluation committee, that they were monitor and will monitor for the next phase, are 5 members, are constituted by 5 members, 1 per each procurer and 2 from the lead procurer. Since for the first phase it was selected 5 companies, they were assigned to each company for doing their supervision. Okay, so and in second phase, well, there was some companies that they weren't selected, and for third phase, well, we don't know which company will be selected. And in fact, each supervisor, what they do, it's to doing progress and review meetings in a timetable that we have very strict. And they need to, and also the supervisors facilitate the interconnection between the buyers group that are the procurers with the contractors to do some co-creation. In fact, in phase 2, we had some beta testing with professional with healthcare professionals and also with expert patients, so-called expert patients. And monthly, these supervisors gather to talk about what they saw in each with each contractor, and also they have to make a report on the deliverables that the contractors are doing during these the phases that they are executing. So, well, this is only to say that there is a protocol that we use for the complaints and conflicts. We used 2 times with one company, but well, I'm not going to say which one. But well, that doesn't matter. And of course, in the end, all of these information is packed and is given to the evaluation committee for them to check if the work is done satisfactory, and that's very important because with that check they cannot be paid, and until now they all being paid. And another check, a very important check, is the successful completion. That is regarding with if the innovative. There is some questions for the evaluation committee for them to assess. And if they don't have this check, they cannot apply to the next phase. That's another thing that's the game for this competition. So in terms of the current progress, right now for the first tender,
Alberto, do you think we can shorten a little bit to give time for our members to ask questions? Because I think I want to have time for our members to ask you some questions, and then I think if you can share the slides, they can go through the more details and go over.
Yeah, okay, but this is the last one. This is the last one. Okay, this is the last slide. This I already mentioned. Well, from the open market consultation, we had 40. We consult 40 entities, and only 11 were submitting proposals to Rosia for the first tender, and from these 11, only 5 were selected. This is the Bahia, ethnic entry, and so on. All of them were awarded for phase 1 for 4 months, and in the end, they applied. All of them applied to the second tender, and only 3 were selected, and already executed the phase 2. So right now we are on the end of the third tender. We are in the step of evaluating the financial offer. So right now we are waiting for the evaluation committee to decide which companies will continue for phase 3, and could be one of these 3: Ethnico Centro, Fundação Mercat, or TNT. So and it will be selected. So that's it. Thank you. Thank you very much.
Thank you very much for this. I think this is an amazing piece of work. I wonder if now there's questions from our audience. Feel free to ask any questions.
Really, I have some things. I find several problems because I was working in similar things from many years ago with elderly people and with people in rural areas in Galicia and so. I think that maybe elder people and people in rural areas don't have the sufficient infrastructures to get a very good service from this. Many times they don't have internet connections with high quality and so. Another thing is that I think that you need focus it in the targets, because maybe I am in mistake, but I think that you have a very general target. So we was working with all people in sorry, because my English is not my principal. Incontinencia urinaria for women is one of the things that the elder people in the rural area are worried about that. Another one is to sleep, and another one is when they fall down to the floor. There are three things that is the most worried for these people. So I think that the applications, the final applications, must be oriented to a very specific and simple targets, not very general and very important targets. So another thing is that the adhesion to the use of these technologies from the people is not easy. That the people, maybe one time they try, 2 times, 1 month, but after that they left. So is you need taking account this situation. Another thing is that the alphabetization, the first knowledge from the people to use these technologies. Many people don't do nothing more than take the phone. No more. And another one is, I can see in your presentation the validation for the European Agency for Medical Affairs or medical devices, because you need to put in the platform one device to use the people. You need one accreditation from FDA or the European agency. And it's no easy to get that. I tried 2 times and I was waiting 5 years from FDA to accreditation. So I think that you need taking account that. And another thing is right now in European Commission are working in the European Health Card Common for everywhere. From the Galicia and north of the Portugal are doing pilot projects using this future health card. So I think that you need includes this health card in the project, because it's necessary for the control of the patients. Maybe in the next future they are working. I think that in 1-2 years every regions of Europe must have a common healthcare. Well, the project is very, very interesting and very useful, and it's necessary, but it's necessary a very big effort in doing, not just to do the projects, to be very useful for the people. Is this the last step is that be really useful, not only one developer of a project. This is my opinion about that, and well, I had a lot of experience in this kind of projects, and it's not easy. Do you have a very, very hard effort to get something good? But well, if I can help you in something, I don't have problem for take a meeting and taking about my experience in this area.
New members for the advisory board.
Yeah.
No, thank you for the comments, because I mean, I think they are all very relevant. And one thing that I didn't mention is that it is true that it's very, I said that it's very ambitious and it's very big in the scope. This is true. One thing that I didn't mention, and I don't really know why, that is that we are not addressing tele-rehabilitation in general, but we selected some pathologies requiring tele-rehabilitation, like a hip fracture, like a stroke. So some conditions that are identified by the professionals for as relevant, and relevant meaning there are cases in different countries participating in the project. And they have experience, the professionals participating, they have experience in the whole care process. But I agree. I mean, when we did the patient involvement here, and then we will see it, there are some things that maybe are not identified as healthcare professional need or issues, and then the patient can identify that the most important thing for them is, I don't know, that I have a fracture and I don't know what to do, or I don't have internet connection. This we know that there are some things that we cannot address, so even in the healthcare system. But the other thing that you mentioned, we have them. I mean, we have them here. We have them in the project. I agree that I don't believe. I think I can say this here now. I don't believe in research by the research, meaning I don't believe that the project should end in a paper or in a line in the CV for the members of the project. So I also want this to be implemented and to be useful for the healthcare system. This is something that I think this tool that the PCP and PPI can it can be a little bit better instrument than other research projects that ends and you don't have the involvement of the healthcare system, you don't have the involvement of the companies, you don't have all the tools and everybody in the line. So, but I mean, we know that this is very difficult, because you've seen all the problems that we have and that we will have for the implementation. So this is true. I can't say anything else.
Sorry for that, but it's,
I
think that is better for you. It's just
it is
to improve
we have them situation. In mind. Also for, as you said, there are some things that maybe they need to be implemented in the future, because we don't know yet that, or they are not yet in the market. So that's why we thought of a platform that is open. That's what we thought, that this can be something static, if you want. That is something that it will change with time. So some applications, maybe they're not working. and we need to change them, or some professionals, maybe they don't like this, but at least in the design and now in the implementation, we are trying to take everything into account, and it's being very difficult. Also because the process Alberto was showing, I mean, this project has a very complicated implementation process defined by the Commission, and also the timetable is very rigid. So this is also something that we are facing. But yes, it is very relevant, everything you said. So thank you for the comments.
My friends, thank you very much for the presentation of the project. We would invite you to share the slides, if that's okay, with our members. I mean, on my side, of course, I'm biased. I've been part of the advisory board of Rosia. Not as active as I would like, but time is very limited for everyone, as well as the ones listening in, and we're finishing today. But I think it's very clear, two things that I wanted to highlight. One is that this is an Iberian project and European as well. And I think that was very well presented by two speakers, Spanish and Portuguese. So I think this is very good, and within the spirit of our society. And then the other thing that seems to me is that, for example, I didn't hear you mentioning any research in terms of academic work and research on the project. Of course, maybe it's part of the work, and I'm sure it's part of the communication and outreach work packages and things like that. But this is perhaps something where a scientific society can also help. And I think we will need to see how we can energize those efforts across the two countries for that. So thank you very much for helping us bring awareness about this project to our community, and then hopefully our community can also be of help to the project. Thank you all, and with this I'm going to close our session, and we will be here again on the next month, same time. Thank you all.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Yeah.
Bye.
See you.